And we see that patients with chronic conditions, they have many, many comorbidities. You can see the crosslink between heart failure, hypertension, diabetes, venous disease, and you can see and list all the risk, the comorbid conditions that occur in these patients.
Patients with advanced venous disease, compared to less severe forms, have more often arterial disease at presentation or will develop during follow-up cardiovascular events leading to cardiovascular mortality. The presence of shared risk factors and pathophysiology is evident, and there are huge implications for risk factor modification, which clearly constitute a paradigm shift.
And these are, again, data coming from the Sweden that clearly demonstrate that not only an intensive, not only an early initiation of lipid-lowering therapy, but a sustained early initiation of effective lipid-lowering therapy is associated with a reduction in adverse cardiovascular outcomes. So in this patient, we should start early and we should guarantee the long-term adherence to the therapy that we are going to prescribe. This again and again are data coming from the Sweden that demonstrate exactly the same message. It is not sufficient to be early, it's not sufficient to be intense, but should be intense, early, and sustained treatment that reduce the cardiovascular risk in all these subgroups that are represented on the previous slide.
No, that our patients are not easy to manage. Patients with chronic metabolic disease, 1 out of 2 of them are not adherent to therapy. Around half of patients with hypertension are not taking the medication correctly. With dyslipidemia, it's even worse because everybody is scared of statin for some reason. So 73% of these patients are not taking their medication appropriately. With diabetes, because they have a target and then there's a team managing them, it's a little bit better, but it's 38% of patients who are not taking it. Now, with someone who had coronary artery disease, you think they have the strongest motivation. You just had an MI. 21% of them do not take their medications. And with heart failure, I think because heart failure is more complex. You know, it's not a single morbidity. It is a multi-morbidity. All heart failure patients have another comorbidity with them. So the actual non-compliance or non-adherence to medication is significantly higher. So we know that there is a challenge in adherence in therapy. There is lack of awareness of the disease and the diagnosis. A lot of these patients who we interviewed for the Enter Aspire, we asked them, do you know what you have? A lot of them will say, no, I don't know, nobody told us. Despite the fact that everybody was told. We know everybody was told because it's part of our protocol. But it's also a lot of information that are given to the patient in a very short period of time. So there is that difficulty in absorbing that amount of medication when they're admitted to the hospital. There's also the issues of a lack of treatment initiation and intensification. We give them the medication and they disappear. They don't come back for follow-up and we don't manage to intensify the therapy. And there's also some personal reasons why patients will not adhere to therapy. And that all translates into high cardiovascular mortality and morbidity.
I'm just to focus on single pill combination, because single pill combination basically is one of the most simple but most effective way to increase adherence. European Society of Hypertension guideline. Yeah, we have one of the panel of the guidelines that, again, they were even more aggressive in terms of blood pressure control, just indicating 120 millimeter of mercury systolic blood pressure as a target for treatment. So that is important. And also those guidelines indicate, suggest the use of single pill combination whenever feasible. But not only European guidelines, can observe how many guidelines, Latin America, Middle East, Asia, all guidelines indicate and support the use of single pill combination to increase adherence to treatment. But unfortunately, again, you see that in Europe, Latin America, Middle East, Asia, look at the utilization of single pill combination, hypertension and dyslipidemia is still very, very low.
And we have evidence that using polypills, or what we call fixed dose combination or single pill combination, then we foster a better compliance. Now, the single pill combinations are recognized as a standard of care, as endorsed by the WHO, and therefore, I think that will be crucial for the holistic approach of patients with cardiometabolic venous diseases, where you can see that because of the common mechanisms that are underlying most of these diseases, the single pill combinations and also the common approach can make they can reduce the number of pills they take by treating several conditions at the same time.
We have to develop an approach which includes all of these people. We have to include patient associations in assessing, supporting, designing. And this is really important, which will be touched on by my colleagues sitting here in the front row. We have to integrate courses of psychology and communication skills, such as process comm, etc., in medical schools. I don't teach psychology in medical schools, but I go in and say, hey, I'm your future patient. Speak to me, learn to speak to me as a person, learn to understand me.